Hello everyone, my name is Bakshi Puneet and today we will discuss about cardiovascular examination. Hello, how are you?
I'm fine, doctor.
What's your name?
Sanjay Bakshi.
Do you have pain on your chest?
No,
Are you feeling unwell?
no.
Okay, let's examine. We'll first start our cardiovascular examination with estimating the jugular venous pressure. Jugular venous pressure or JVP is a measurement of the highest oscillation point or meniscus of the jugular venous pulsation. This measurement reflects pressure in the right atrium, that is central venous pressure. The JVP also provide valuable information about the patient's volume status and cardiac function. Estimating the patient's JVP is one of the most important and frequently used skills of physical examination and often the first step in our cardiovascular assessment. The JVP is best assessed from pulsations in the right internal jugular vein. First, adjust the head of the examining table to 30 degrees with the patient supine. Place the patient's head on a pillow just to the top of the shoulder to relax the sternocleidomastoid muscles. Then adjust the patient's gown and drape as necessary. Both sides of the neck, then turn the patient's head slightly to the left since the physical examination is conducted from the patient's right side. Focusing on the right side, identify the external jugular vein, then find the internal jugular venous pulsations, and if necessary, raise or lower the head of the bed until you can see the oscillation point of the internal jugular venous pulsations in the lower half of the neck. Look for oscillation point along the sternocleidomastoid muscle between the clavicle and angle of jaw or just posterior to the sternocleidomastoid. Internal jugular pulsations have a soft undulating quality with 3 elevations per heartbeat, 2 of which are visible, and 2 troughs where carotid pulse has a more vigorous thrust with a single outward component. Internal jugular pulsations are rarely palpable. The height of the internal jugular pulsation usually falls with the inspiration. Now measure the oscillation point of pulsation in the right jugular vein using the following technique. First, extend an elongated rectangular object such as 3 by 5 card from the meniscus point of pulsation while extending a centimeter ruler vertically from the sternal angle, making a right angle to establish the true vertical and horizontal line. Place your ruler on the sternal angle and line it with the vertical line in the room. Then place your card or other rectangular object in an exact right angle to the ruler. This constitutes your horizontal line. Make sure one edge of the card is at the point of oscillation of the jugular venous pulsation. Making sure to keep the card horizontal, read the vertical distance from the card crosses the ruler. This measurement identifies the jugular venous pressure or JVP, which is the vertical distance in centimeters above the sternal angle where your card crosses the ruler. Round your measurement off to the nearest centimeter. Next, we will assess the carotid pulse. The carotid pulse provides the valuable information about valvular heart disease and is especially useful for detecting aortic insufficiency. Your assessment will include both palpation to assess the amplitude and contour of the carotid upstroke and auscultation for the presence or absence of bruits from turbulent blood flow. First, inspect and palpate both the right and left carotid artery, then compare. However, do not press on both carotid and artery at once since syncope may ensue. Place your index and middle finger or your thumb on the right carotid artery in the lower third of the neck. Then press just inside the medial border of the well-relaxed sternocleidomastoid muscle, roughly at the level of cricoid cartilage. Slowly increase pressure until you feel a maximal pulsation, then slowly decrease pressure until you best sense the arterial pressure wave and contour. Now just tell the patient to turn head and hold breath. After palpating the carotid artery, listen carefully over both the arteries with the diaphragm of your stethoscope. Some examiners use the bell. Ask the patient to hold breathing for a moment so that breath sounds do not obscure the sound of turbulent flow. Listen for a bruit, which is a wishing murmur like sound often from atherosclerosis. Now we will do examination of the heart. The examination of heart consists of inspection, palpation and auscultation. Stand at the patient's right side. Have the patient remain supine with the upper body raised to 30 degrees. First inspect the anterior chest, noting any heaves or lift. None are observed here. Careful inspection may also reveal the location of the apical impulse. Later in the examination, we palpate to more clearly identify the apical impulse. Now first proceed with palpating the chest wall. First palpate for heaves or thrills. Using our finger pads, hold them flat or obliquely on the body surface as you palpate in the right and left second interspace, along the left sternal border and in the apical area. Ventricular impulses may heave or lift your finger, suggesting ventricular dilatation. None is seen here. Then check for thrills by pressing the ball of your hand firmly on the chest in the same location. If subsequent auscultation reveals a loud murmur, go back and check for thrills over that area again. Using the palmar surface of the several finger, then for the final assessment, use fingertips, which is followed by one finger alone. Palpate to confirm the characteristics of the apical impulse. Then we will note location, amplitude, and we will identify the location of the apical impulse by interspaces in which we feel it and by distance in centimeters from the mid-sternal line. If we experience difficulty locating the apical impulse, ask the patient to tip or partially roll on to his left lateral decubitus position. Then palpate again using the palmar surface of several finger. Measure the distance of the impulses in centimeter. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. Next, feel for the right ventricular impulse at the lower left sternal border. While keeping one finger in the third interspace, place additional fingertip in the fourth and fifth interspace. Then feel for the right ventricular impulse in the epigastric or subxiphoid area. Now we will begin the auscultation sequence. Adjust the stethoscope so that we can listen through the diaphragm. Begin listening in the aortic area at the right second interspace close to the sternum. Starting in the right second interspace, help orient us to cardiac cycle. Note the cardiac rate and rhythm normally. The rate is 60 to 100 beats per minute and the rhythm is regular. Identify S1 and S2 in the aortic area. S2 is usually louder than S1 in this area. S2 is usually louder than S1 in the pulmonic area. Now just tell the patient to breathe in and out. Still listening in the pulmonic area, try to identify the inspiratory splitting of the S2 into its two components. Its first component A2 is from aortic valve closure. Its second component P2 comes from pulmonic valve closure. The physiological splitting of the S2 usually occurs during inspiration, and during expiration, however, these two components are fused into a single sound. Now, as we listen again, usually S1 diminishes in intensity while S1 becomes louder as we proceed down through the third interspace and into the tricuspid and mitral areas. Now switch to the bell of the stethoscope. Listen next along the lower left sternal border in the left, fourth and fifth interspaces. Then listen to the apex. Now tell the patient to move into left lateral decubitus position just to improve our ability to hear S3 and S4 sound and the murmur of mitral stenosis. Place the patient in the left lateral decubitus position. Have the patient roll partway onto his left side. This brings the left ventricle closer to the chest wall and makes low pitched sound more audible. Then recheck the position of the apical impulse and place the bell lightly over the location. Now palpating the carotid pulse as we listen can help with the timing. First decide if we are hearing a systolic murmur falling between the S1 and S2 and coinciding with the carotid upstroke, a diastolic murmur falling between S2 and S1 falling before or after the carotid upstroke. Murmurs are classified according to where they fall in systole and diastole. Palpating the carotid pulse as we listen to the murmur is an important tip that helps to decide if the murmur is systolic or diastolic. Systolic murmurs can be early, mid, or late systolic, or even pansystolic.